Hey everyone! Today, we are stripping away the pop culture myths and completely decoding the clinical reality of alcohol use disorder, or AUD for short. We're going to use strictly facts pulled directly from modern medical preceptor materials for this explainer, taking you on a journey right through the clinical data. We are moving step by step from diagnosis to some truly groundbreaking new definitions of recovery. If you want the direct, unvarnished truth about how modern medicine actually understands and treats AUD, well, you are in exactly the right place.
Okay, let's dive into this roadmap so you know exactly where we're headed. We'll start with the reality of alcohol use, move into screening and diagnosis, and then unpack a massive treatment gap. After that, we'll cover therapies and medications, redefine recovery, and wrap up with ending the stigma.
Section 1, the reality of alcohol use. I want you to just momentarily set aside whatever you think you know about how common this condition actually is. Look at this fraction, 1/3. On a lifetime basis, almost 1/3 of people in the United States will meet the criteria for alcohol use disorder. That is staggering, right? This isn't just some niche issue. It is a pervasive, massive public health reality. And clinically, it's absolutely crucial to understand that this isn't merely a bad habit. It fundamentally alters the brain. Think of it like rewiring a house's electrical panel. Long-term exposure causes adaptive changes in critical neurotransmitters, things like GABA, glutamate, and norepinephrine. Those neurological changes are exactly what lead to the tolerance and physical dependence that literally define the disorder. To put that into an annual perspective, just look at this number, 29.5 million. That is the estimated number of individuals who meet the criteria for AUD every single year. On top of that, more than 140,000 deaths are attributed to alcohol annually. Grasping the massive medical scale of this condition is so important because it frames everything we're going to discuss next. We're talking about a chronic, widespread medical condition that demands a highly structured response. So how does modern medicine actually go about identifying it? Section 2, screening and diagnosis. The absolute gold standard for diagnosis comes straight from the DSM-5. And what's interesting is that it definitively frames alcohol use disorder not as some failure of willpower, but as a problematic pattern of alcohol use that leads to clinically significant impairment or distress over a 1-year period. It's measured against 11 specific symptoms. These are categorized into physical symptoms like building a tolerance, experiencing withdrawal and intense cravings, and behavioral symptoms like neglecting your daily activities or just continuing to drink despite the obvious problems it's causing. The diagnosis scales directly with those symptoms. Having 2 to 3 indicates mild AUD, 4 to 5 means moderate, and 6 or more classifies as severe. And this brilliantly illustrates how fast this process can be in a clinical setting. Primary care providers use a screening tool called the Audit-C. It literally takes only 1 to 2 minutes to administer. Instead of some long, complex psychological evaluation, it relies on scoring 3 very simple, specific steps: your frequency of drinking in the past year, the quantity of drinks you have on a typical day, and the frequency of binging, which is having 6 or more drinks on one occasion. It's a rapid, highly sensitive tool designed specifically to pinpoint heavy drinking days. But identifying the problem leads us to a seriously concerning reality. Section 3, the treatment gap.
Now, what's really interesting about this 2021 survey data is the sheer dramatic tension it reveals. Despite the tens of millions of individuals meeting the criteria for AUD, only 8.3% of eligible persons actually received therapy. Let that sink in. That leaves a massive 91.7% of people completely untreated. I mean, imagine if over 90% of people with broken arms just never got a cast. That is the systemic treatment gap we are dealing with here.
Section 4, therapies and medications. The good news here is that evidence-based treatments absolutely do exist to close that gap. Clinical treatment is essentially divided into 2 main pillars. On one side, you have your behavioral treatments, things like cognitive behavioral therapy to modify thought patterns, motivational enhancement therapy to help patients collaboratively recognize the harms of their use, and, of course, highly utilized mutual support groups like Alcoholics Anonymous. But the second, often lesser-known pillar relies on FDA-approved pharmacological medications. For patients with moderate to severe AUD, combining both psychosocial interventions and these medications is usually the absolute most effective route. Let's look a little closer at these FDA-approved meds. There are 3 primary drugs you really should know about. First up is naltrexone. It works by blocking the mu opioid receptors in the brain, which basically blunts the rewarding effects you'd normally get from alcohol and reduces cravings. Next is acamprosate. This one actually modulates the GABA and glutamate activity in the brain that we talked about earlier, helping patients maintain abstinence. Finally, there's disulfiram. This is an older drug that inhibits a specific enzyme in the liver. If a patient drinks alcohol while taking it, it causes an immediate buildup of a toxic byproduct called acetaldehyde. That results in severe nausea, vomiting, and flushing. It works entirely through negative reinforcement for patients who are highly motivated to abstain.
Now, because there are only those 3 FDA-approved medications, clinicians will often successfully repurpose other existing drugs, prescribing them off-label to help out. Gabapentin and topiramate are both used to modulate brain neurotransmission to decrease heavy drinking days. Baclofen is incredibly useful, especially since it's recommended as a safe alternative for patients who might already have alcohol-related liver disease or cirrhosis. And varenicline, which you might actually know as a smoking cessation aid, can be a huge help for patients who are drinking heavily and concurrently smoking. Understanding these diverse options brings us to a major narrative plot twist regarding the ultimate goal of all these treatments.
Section 5. Redefining recovery. So the crucial point is that the medical community has completely modernized its view on what success looks like. Historically, complete, 100% total abstinence from alcohol was viewed as the only effective way to recover. But in September 2020, the National Institute on Alcohol Abuse and Alcoholism, the NIAAA, released a brand new research definition of recovery. It no longer strictly demands total abstinence. Instead, it shifts the focus to harm reduction. The 2 key components are now simply remission from the DSM-5 AUD symptoms and the cessation of heavy drinking. Let me read you the exact quote from the NIAAA. Recovery is a process through which an individual pursues both remission from AUD and cessation from heavy drinking. This is a huge paradigm shift because, let's be honest, total, lifelong abstinence was perceived by many as an impossibly high bar, and that fear was deterring millions from getting life-saving treatment. By shifting the focus to harm reduction and just improving overall quality of life, medicine is radically lowering the barrier to entry for getting help. Section 6, ending the stigma. Which brings us to the real elephant in the room. If we have the diagnostic tools and we have the treatments, why does that massive 91.7% gap still exist? Well, the simple truth is that alcohol use disorder is among the most highly stigmatized medical conditions on the planet. It is so often falsely viewed as a personal moral failing, and that elicits intense social rejection. But the clinical facts completely contradict that idea. Medical data shows that nearly 50% of AUD risk is purely heritable. It's literally in your genetics. The other 50% comes from environmental factors. It's vital to understand this, particularly because women face a much higher cultural stigma regarding alcohol problems, which often prevents them from seeking care, even though they're at risk for a much more rapid progression of the disease and liver damage. Let's move to see how this builds into a practical strategy we can all use every single day. The World Health Organization and the NIAAA both emphasize that reducing stigma isn't just nice to do, it's a primary medical directive, and it starts with our words. Using stigmatizing language like calling someone an alcoholic or an alcohol abuser reinforces that false idea of a moral failing. Even the word relapse carries some heavy negative baggage. The clinical shift is to use empathetic, person-first language. We say person with AUD, focusing on their humanity first, and we use the phrase return to use instead of relapse, treating it as a standard medical symptom rather than a personal defeat. So, we've seen the scale of the disorder. We know the neurobiology is very real, the diagnostic tools are rapid, the medications are effective, and the clinical definition of recovery has evolved to be more forgiving and inclusive than ever before. Yet over 90% of people still suffer in the shadows. So I'm going to leave you with this provocative thought. If modern medicine has evolved past the rigid demands of total abstinence and those stigmatizing labels, how can changing our own everyday words, literally just how we speak about this condition with our friends, families, and colleagues, be the very key to finally closing that 91.7% treatment gap? Knowledge is power, but empathy is the bridge. Thanks so much for exploring this explainer with me today. Keep questioning, keep learning, and I'll catch you next time.